Good evening, everyone. Welcome to these sessions. My name is William Chen. Before joining GenFund, I work as the clinicians in critical care and the anesthesiology department for 13 years. Now, as a senior medical director at GenFund medical team, I'm very glad to see so many experts here. Today, our topic is new research on the emerging role of hemoadsorption. This is very important field that is changing how we treat critically patients today. Before we start the keynote speech, I want to share a brief update on GenFund's programs in critical care field over the last few years. First, from support to the cold treatment. In the past, hemoadsorption was often used as the last resort, but now, with our HA and CA series, it has become a core part of early treatment. We are seeing it widely used in the sepsis and ARDS and the cardiosurgery to control the cytokine storm. Second, we focus on the evidence-based medicines. We know that data is the most important thing for doctors. In recent years, GenFund has supported many high-quality RCTs and multi-center studies. We are not just curing toxins, we are proving that is technology can improve hemodynamic, microcirculation functions, and organ function protections and help patients leave the ICU sooner. Third, technology is becoming more specific, especially critical care is very, very complex. We are moving from general absorptions to specific absorptions. We now have products specifically for endotoxin removal and immune regulations. This helps doctors provide more personalized treatment for different patients. Finally, our global presence. Today, GenFund's products are used in over 100 countries. Our technology is being included in more international guidelines and expert consensus. We are very proud to share the Chinese innovations with the whole world. We believe there is still a lot of discover about the hemoadsorptions. That is why we have here today to listen and the latest research and share our experience. Now, please let me show our agenda. At the first is the opening and welcome, which we are doing right now. And the second is the last research programs on hemoadsorption in sepsis. We will hear about the most recent scientific data. The third is hemoadsorption in sepsis, the state of the art. It's a deep dive into current best practice and the clinical applications. After that is the expert panel discussions. We will invite two other top experts to the stage and discuss the future of our field. And after that, if anyone have the questions or want to discuss with ours, you can type your question in the chat box or just hands up in the Q&A sessions. At the end is the closing key takeaway. We will summarize the main points of the end of today. Now, let us start our first presentations. It is my great honor to invite Professor Fatigue to his talk on the latest research programs of hemoadsorption in sepsis. Professor Fatigue, he is the Divisions of Intensive Care Department of Anesthesiology and Reanimations, Marmara University, Pendik Training and Research Hospital from Istanbul, Turkey. So let's welcome Professor.
Thank you very much. Thank you very much. Dear audience and all participants, first of all, I would like to express my special thanks to Jeffrey for organization of this webinar. And today I will talk about the use of hemoadsorption therapies in sepsis, actually. And our study recently published in the Turkish Society of Intensive Care journal, which related to this topic. Now, I want to share my presentation. Is it clear?
Yes, we can see that, sir.
Thank you very much. My name is Fethi Gül. I'm an intensivist and I study in Marmara University in Istanbul. And today I will talk about some points about the hemoadsorption in sepsis and our main study which will refer to hemoabsorption treatment in sepsis. As you know, sepsis is one of the main causes of morbidity and mortality in critically ill patients. In 1991, the Consensus Conference developed an initial definition of sepsis, which related to source and source with and also with infection. It means and sepsis. And in the time, the sepsis and septic shock definition terminology revised first in 2001, and lastly in 2016, and the new definition is now we use. And if you look the new version of definition, there are some organ dysfunction and as a result of infection, and some organ dysfunction occurs, and this means sepsis. And also septic shock is a subdivision of sepsis, which is very harmful and with a high level of mortality and morbidity. So sepsis now defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And now we just have sepsis and septic shock defined as subset of the sepsis, and which has a greater risk of mortality than sepsis alone. And if you look at the global epidemiology of the sepsis, and you can see very alarming signals and very important numbers, because every year 49 million cases occur globally, and 11 million deaths occur because of the sepsis. 1 in 5 deaths, all deaths around the world are associated with the sepsis. And if you look the children under 5 years old have a big risk for sepsis mortality also. And for the pathophysiology of septic shock, we can say sepsis initiates a complex interplay between pro and anti-inflammatory process, and at the same time also. And for pathobiology of the sepsis, inflammation results from a stimulus signaling from damage or an infectious. And if you talk about sepsis, first we have to check the pumps. Pumps mean pathogen-associated molecular patterns. This can be a virus, a fungal balls, or a bacterial cell wall. And these microorganisms bind endothelial pathogen recognition receptors, and then you can see some inflammation pathways. Hyperinflammation in another during the COVID-19, you can remember a cytokine storm, and it means the same, actually, hyperinflammation. It results from a stimulus, signaling damage or infection. And so there are some important issues about hyperinflammation. Inflammation in sepsis actually driven by leukocytes, some oxygen radicals, and some endothelial cells, and also complement system, coagulation system also, and some necrotic pieces. And during the sepsis, individual immune response determined by many factors, including pathogen virulence and the size of the bacterial inoculum, and also patient comorbidities are very important. And if you look to hemoabsorption treatments, we have some hypotheses. And the first hypothesis is cytokine peak hypothesis. It was first described in 1993 by Professor Ronco. And this cytokine peak hypothesis is very important because this theory suggests that the peak level of some different molecules are eliminated by continuous hemoperfusion techniques. And when mediators with highest concentration and remove more efficient and in larger amount, This means if you remove these mediators, so you can see low level of local deletion effects, and it means low level of organ dysfunction. By this way, you can reconstitute the immune homeostasis also, because antigen presenting capacity of monocyte increase by these cytotoxic levels. And a new equilibrium between the innate and adaptive immunity occurs. This is the first hypothesis. And the second hypothesis is the threshold immune modulation hypothesis. And this suggests that decrease and removal of cytokine from the blood mobilize cytokines from the tissues via concentration acquisition. And this means decrease local delicious effect of these cytokines. This is another hypothesis of hemoabsorption. And the last and the third one is the cytokinetic model. This model means removal of inflammatory mediators by these extracorporeal blood purification techniques, increase the cytokine and chemokine concentration gradient from plasma to infected area. And after that, leukocyte trafficking is driven towards the needles of the infection. And end result is local bacterial clearance. And all these theories modulate inflammatory mediators to restore a balanced immune response. This is very important. Another important issues about this immune modulation is a recently published report suggested and described extracorporeal blood purification techniques may control immune dysregulation in sepsis by removal of these endotoxin, inflammatory mediators, and cytokines. And this was a very important suggestion. You can see here some molecular classification in nature. We have small, middle, large, and also essential protein albumin. If you talk about hemoabsorption, our target molecules are middle and large size molecules. And if you look, you can see many pro and anti-inflammatory cytokines are in this at this stage. And also myoglobin, one of the important molecules which related to rhabdomyolysis, also with 70,000 molecules related to this molecular classification. And here you can see some extracorporeal blood purification methods, and hemodialysis is studied with diffusion. And if you look at hemofiltration, you have to say the convection methods, and also hemoperfusion method in another names, hemoabsorption treatments are absorption methods. So the nature of the mediators and their molecular size make hemofiltration and hemodialysis highly inadequate for actually for the condition of the sepsis. So if you use an absorption technique, maximally you can remove this type of the mediators from our body. So we can check the hemoabsorption. Hemoabsorption treatments introduced the mechanism of absorption. They achieve extensive clearance and also effectively remove a wide range of the toxins, including protein-bound molecules and middle to large size molecules that hemodialysis or hemofiltration alone cannot address these molecules. And we have many studies in the literature, and they show different results. And there is a question mark still we have a question mark in our mind. And what is the problem? Actually, the problem is heterogeneity of the patients, because heterogeneity of critical care patients poses a significant challenge for influence of the host responses and to infection. So selection of the patient is very important because some patient may react differently, and it depends patient to patients. And we have to choose the real method, and also we have to choose the real patients, and also maybe we can use in the future some immune phenotypes and biomarkers-based protocols in the future. Now I want to talk about our studies and our studies which was published in Turkish Society of Intensive Care Journal news, and it was recently conducted the treatment protocols. And as you know, hemoabsorption techniques as adjuvant therapy for refractory shock, and there's still clinical evidence regarding its effectiveness remains inconsistent, largely due to some patients' heterogeneity and the real time of the therapy initiation, and also differences in treatment protocols. In our center, hemoabsorption with HA330 cartridge was incorporated in the sepsis management protocol for the patients who are refractory septic shock and who have high vasopressor requirements. And this study was conducted in our center to evaluate the clinical impact of these protocol-based hemoabsorption strategies on outcomes with septic shock patients. Our study objective was evaluate the clinical efficiency of protocol-based hemoabsorption therapy using the HA300 cartridge. And we have some outcomes, and our first outcomes was 28-day mortality. And if you look at the secondary outcomes, you can see some organ dysfunction score change and vasopressor recurrent and acute kidney injury incidence and healing of the acute kidney injury, and some lactate levels, problem with the lactate, and ICU and hospital length of the stay. It was a retrospective study, actually, and it was a single center observational core study. In our center, we follow mixed ICU patients, and we have 58 ICU beds. The study period was between the January 2023 and between the June 24. And we include the patient who have septic shock and who stay longer than 24 hours in ICU. During the study period, we screened 2,533 patients, and after exclusion criteria, and these were non-septic patients, patients with missing data, and patient who stay was under 24 hours, pregnant patients, and patients who were under the 18 years old. After these exclusion criteria, we analyzed 127 patients, and we divide the patients into two groups. On what sites, a hemoabsorption group, and 52 patients were in this group who were received HA330 therapy. And in the second arm, we had a control group with 75 patients. And I want to talk about our hemoabsorption protocol. In our institutional protocol, hemoabsorption was considered in patients with sepsis when there is a refractory septic shock, and this means a high inflammatory burden. For this therapy, when norepinephrine dose exceeds to 0.2 to 0.25 microgram per kilogram per minute, we add a second vasopressor or inotrope agent, and also we use steroid therapy. But at this point in our study, we start also hemoabsorption treatment. When a CRRT was required, we combined and integrated the HA300 cartridge into the CRRT circuit. But if there is no receiving CRRT treatment, hemoabsorption was performed in a hemoperfusion mode using dedicated devices. And we use 1 session per day for 3 days for this treatment. Each treatment lasts for 6 to 8 hours per session, and it means blood. It depends on blood flow, the treatment time. And if you look and some demographic information, demographic characteristics, and ICU disease severity score and vasoactive inotrope scores, there were no significant difference at the baseline between these groups in terms of the gender, body mass index, Charlson comorbidity index, and other severity scores. Within the 72 hours of the ICU admission, there was no any difference between the groups in terms of the vasoactive inotrope score, norepinephrine, adrenaline. Also, we use methylene blue, and there is no any difference between in terms of amount of these drugs, and like the taripracin or and also steroid treatment was not different between the groups. And if you look organ dysfunction score, SOFA score were similar at the ICU admission between the treatment and control groups, and there was no any difference observed on day 1 and day 2 between the groups also. But by the day 3, the SOFA score was significantly lower in hemoabsorption group, and this was the main difference between the control and hemoabsorption group. And also, if you look the group analysis, a significant decrease in lactate level was observed in hemoabsorption group on day 3, if you compare it with day 1 and day 2, but there was no any significant change in the lactate level in the control group. And another important issues about acute kidney injury, and a large proportion of the patients from hemoabsorption group had acute kidney injury on day 1, and it was more common if you compare to control group, and 71% for hemoabsorption group and 44% for the control group. And the proportion was similar in the two groups on day 2 and day 3, as well as on ICU discharge. And this difference disappeared over the 3 days follow-up, suggesting a beneficial effects of hemoabsorption on renal dysfunction. And also, if you look, CRRT use was significantly higher in hemoabsorption group, and CRRT duration was longer also in hemoabsorption group. And our main results, our primary outcome was mortality. And if you look, 28-day mortality was very low in hemoabsorption group. A significant reduction of the mortality was seen in hemoabsorption group. If you compare, the mortality rate was 30.8% in hemoabsorption group and 49.3% in control group. And if you look to length of the stay, ICU length was not different, but in hemoabsorption group, HA300 group, hospital length of stay was longer. But this mean in this study, the longer stay in hemoabsorption group likely reflects as survival and ongoing recovery after the treatment. At the end, I want to give some message from our study and some message and who you can take to home message. Early, not too late, protocol-based hemoabsorption treatment associated with a significant reduction in 28-day mortality in critically patients with septic shock. And I can say in hemoabsorption group, the infection burden was higher also, and also a higher rate of the acute kidney injury at the baseline in hemoabsorption group. And hemoabsorption was associated with earlier improvement in organ dysfunction, and we show that low SOFA score at the day of 3. And it may indicate a positive effect on organ recovery in refractory septic shock. And there was no significant group differences was observed in early hemodynamic parameters, but decrease in lactate levels and improvement in acute kidney injury trends suggest a potential benefit on tissue perfusion, also microcirculation, and also renal function. These findings are very important because the idea that timing and patient selection is very critical, and we have to select the patient according to some protocol-based patients. And longer hospital stay in hemoabsorption group likely reflects a improved survival rather than worse outcome in our study. Thank you very much for your attention.
Thank you, Professor. Let us thank Professor Fettigrew for sharing this impressive result. As a former doctor, I find these findings very encouraged, I think, especially seeing the significant reductions in 28 days mortalities. The protocol based on HA330 treatment is a major clinical milestone, especially considering the HA group actually had a higher infection burden and more AKI at the baseline. So now that we understand the clinical impact on mortalities and organ recovery, how do we translate this into the best clinical practice at the bedside? To answer this, our next session is Hemoadsorption in Sepsis, the state of the art. It is my great pleasure to invite Professor Ranita from Siriraj Hospital, Mahidol University, Bangkok, Thailand, to the stage and share these latest clinical strategies. Professor, please.
Okay. Can you hear me right now?
Yes.
Okay, sorry for technical problems. So for today's topics, I would like to speak like the principle, firstly for the principle of hemoperfusion and cytokine absorption. If you see into the sorbent here, you can see in the cartridge or sorbents contain of like a solid particles packing into a cartridge with various size of particles. It provides extremely high surface area and classify according to pore size into macro, meso, and microporous. If you take a look for only one particle, you can see that only one particle, you have a lot of surface area, both outer surface and inner surface. But unfortunately, with the help of physical adsorption and chemisorption, if the toxic substance like cytokine trap into the surface area, it's gonna be like a full or saturation. This is the main reason that they show like adsorption isotherms. Absorption isotherm or sorbent-based saturation, leading to tendency for longer duration of treatment, mainly to saturations and clottings. These depend on types of sorbents, design of cartridge, and concentration of solute. As you already know that PAMs, DAMs, in sepsis provide a lot of cytokines like cytokine storm or cytokine releasing syndrome. We need to use the hemoperfusion with cytokine adsorbent or endotoxin adsorbent for removal such toxic substance. However, a lot of cytokine or foods or much more level of cytokine may lead to cytokine like saturations. So if we divide for the target of adsorbent in sepsis, you can divide into selective like or non-selective. For selective, we can adsorb pathogens like lipopolysaccharide, or non-selective, we can adsorb cytokine like this. Here is current available extracorporeal blood purification device in sepsis. Now we have CLAF 100, which can direct adsorb the bloodstream pathogens. We have torremixin, which adsorb mainly endotoxins from gram-negative organisms. We have cytosorb and HAT30 or T80 for adsorb cytokines. If we divide into selective, for example, adsorb only pathogen or endotoxin, or non-selective adsorb cytokine. If we can use both together, maybe provide better benefit in terms of other than select the right patient, maybe we can use like a sequential treatment, as I will show you later. For technical aspects, in brief, we can use hemoperfusions, only like a direct hemoperfusion run the blood through the softband. Or we can connect it with hemodialysis or CRRT as Professor Felty already showed to you. Or we can conduct with the corporate this softband circuit into ECMO circuit. However, the main question is that how about the optimal duration in relation to blood flow, cartridge saturation, and clotting risk? This picture shows that for different kinds of sorbent like tolemicin, cytosorb, Osilis, or HAT30, there are different duration of treatment from 2 hours, 6 hours, 24 hours. So about longer treatment is maybe lead to absorb like a saturation or maybe lead to absorb some kind of antibiotic. For shorter duration maybe lead to inadequate dose of absorptions. For example, for polymyxin immobilized toxin, the first study like a UFAS study show beneficial effect in for 28-day mortality compared to the standard treatment. However, others therapy with the polymyxin B immobilized fiber show negative result in terms of mortalities. Even if in case with they calculate or they can measure the EEA or endotoxins assay of higher than 0.6, like a Euphrates study show negative in terms of survival. So how about this? If we move into the cytokine adsorbent like cytosorbs, the first randomized control study for cytosorb conducted by Professor Schneider failed to decrease 28-day mortality in sepsis patients with acute lung injuries. However, it can decrease the blood concentration of interleukin 6, interleukin 8, and MCP1. For hemoadsorption in combination with ECMO system, a randomized control trial showing that cardiopulmonary bypass using combined with cytosorb during cardiac surgery for infective endocarditis patient or removed study show no benefit in terms of delta SOFA score and 30 days mortality. How about HAT30s? Small sample size randomized control study show that HAT30 treatment adjunctive with standard treatment in sepsis can reduce interleukin 6 and vasopressor dose and trend toward lower 28-day mortality. However, in this group of patients, only 50% has shock. So most of cases has only sepsis, no shock, not so severe for this group of patients. However, despite the surviving sepsis campaign recommendation suggests against using of polymyxin B hemoperfusion and other kinds of extracorporeal blood purification technique. The survey in Europe show that more and more data gonna do adjunctive hemoperfusion, even used with endotoxin adsorption or cytokine adsorptions. So how about to select the right one or the right patient for our case, or how to select the good case who can have beneficial effect from the cytokine adsorbents? Then the main research question gonna be correct, select the right patients, the criteria of initiation, cessation, and optimal absorption dose for a given patient. How can we do? We then conduct the clinical trial like CLINS study. This is the multi-center randomized control study in Thailand. We include only the patient of septic patients who has the norepinephrine resistant cases or more severe cases, combine adjunctive hemoperfusion with HAT30 with standard treatment and to see how the affecting 28-day mortalities. We include septic shock and we set the level of norepinephrine like higher than 0.2 microgram per kilo per minute or more. But we know that if we start too late, it's going to be not so good for adsorption therapy. Then we exclude case if the threshold of this level of vasopressor achieve more than 1 day. So we like start very early within 24 hours or if possible within 12 hours of cases. After second interim analysis for 4 years, we can eligible case 186 cases and randomize to 65 in treatment group, in standard group and 63 in hemoperfusion group. Both groups has comparable in terms of severity, age, SOFA score, time since sepsis diagnosis. The mean APACHE-2 score had like 26 in standard treatment and 28 in hemoperfusion treatment. And we can start the treatment after the norepinephrine achieve the level of 0.6 microgram per kilo per ounce. After that, still like 6 hours and 8 hours after the achievement of high dose norepinephrine treatment. For the dose, when we start the treatments, the vasopressor dose or norepinephrine equivalent was 0.37 in standard treatment group and 0.38 in hemoperfusion group, and lactate around 5 to 6 in both groups, with very high interleukin and C-reactive protein. This show that the patient was in pro-inflammatory process like a cytokine storm. This slide shows Kaplan-Meier of 28-day mortalities. 28-day mortality trend toward better in hemoperfusion group when compared with standard treatment group. However, it's not achieved the statistic significant. We have to wait for finish the treatment. However, our case can collect very slowly because we very selective the case. Then we plan to stop because of very slow recruitment the treatment. For organ support like mechanical ventilation, stopping with mechanical ventilation, vasopressor, and stopping RRT or ICU discharge, no different in both groups. For the shock reversal trend toward better in hemoperfusion group. Interleukin 6 for the median level of interleukin 6 higher in hemoperfusion, but after treatment trend toward better in hemoperfusion group again. In summary, clinical studies show that in patients with norepinephrine resistant septic shock adjunctive hemoperfusion with HA330s, a cytokine absorber, show trend toward better 28-day mortality, but not statistic significance. The limitation is that we conduct the treatment like 3 hours of hemoperfusion only for 2 sections on first day and second days. And we strictly list selection of the patient, so slow enrollment, then we found that very slow enrollment, then we have to stop after second interim in analysis. So if I want to extrapolate some from my study, what about the right patients, criteria for initiation and for the dose? Let's see the concept of sequential extracorporeal therapy in sepsis. Professor Ronco and his group show that it would be good if we can absorb after the infection attached our patient, like for the pathogens, like lipopolysaccharide or endotoxins, then for cytokine storm and treatment after organ damage occurs. For example, we can use pathogen absorber like CLAP 100 combined with endotoxin absorber and then combined with cytokine absorber. Another point is that some retrospective study data show that amount of the blood purification which equal to treatment duration times the blood flow divided by the body weight of the patient show that if higher dose, like higher amount of blood purification, show better in terms of mortality than lower amount of blood purification. For our group of patients, we conduct only 2 treatment group and only 2 hours for 1 session, because firstly we think about saturation during cytokine absorber, and we think about the antibiotic absorption. This maybe give the worst outcome for our patients. Another point and another paper show that with cytosorb or cytokine absorbent, the treatment with higher dose show less mortality. However, this is like a post observational study. Higher sessions, early starter associated with better in terms of mortality outcome or survival benefit. So if we look about CAT30 of Jafron, they combine endotoxins and cytokine within 1 cartridge. It would be nice if we can use like a concept of sequential treatment, as Professor Ronco mentions. For example, we use CAT30 combined with HAT30 or HA380 for 3 days and use longer duration than our study. For example, like 6 hours per sessions. For first day, which had a lot of or higher level of cytokine storm, maybe we need 2 treatment, either 2 cartridges of CAT30 or 1 cartridge of CAT30 and another one with HAT30 for combined endotoxin absorptions, cytokine absorption together. I would conclude that how to select the right patients, we have to think about target solute. If we can use sequential extracorporeal therapies, firstly attached with endotoxins, then with cytokine storm, target at different levels. We have to select not to mind the patient who can survive without adjunctive hemoperfusion for sure, but not select the bad guy like 2 severe cases. For example, like our study, we select only septic patient require higher dose of vasopressor. We select it by see some case with CRP level or interleukin 6 level, which very higher in our cases, not too sick patient, not too late patients. The right time should be as soon as the criteria of severe attached, like within 12 to 24 hours after higher dose of vasopressor achieved. For the right dose, maybe longer and more than 3 sessions. Here is the advice from panel by group of Professor Rongo and Chong-Lui Wong-Songs by the use of extracorporeal blood purification SEPSIS. They suggest that we have to select only severe case, consider different kind of softband if as indication like a renal support, remove cytokines, or including with ECMO. Higher level of severity like high SOFA score, high norepinephrine 0.2 microgram per kilo per min, higher lactase. Start very early within 12 or maximum at 24 hours. And we can continue and to see how about the hemodynamic response or shock reversals. Let I show you this picture. We have to select in zone B, which has cytokine storm, then maximize benefit from extracorporeal blood purification. If we do in too late the step, like concurrent or has the counteractive anti-inflammation or immunoparalysis, it might lead to some kind like decrease the cytokine levels and induce organ function, organ dysfunction, and less survival. This is the bad part of hemoadsorption techniques. Another part that we have to think regarding the antibiotic removal during the cytokine adsorbent. For example, cytosorb has a lot of adsorbent like fluconazole, linezolid, and other treatment. For HATX, Professor Bellomo conducted the study and showed that vancomycin and gentamicin has less level after treatment with hemoadsorption with cytokine. I would conclude that this technique gonna be like highly variable worldwide. We need to tailor-made to individual patient condition, like I already mentioned, should be performed early when the level of endotoxin and cytokine are extremely high. For the later, maybe other kind of treatment like organ support or high cutoff membrane may be better for that situation. Thank you very much for your attention.
Thank you, Professor. Thank you, Professor, for this excellent clinical guide. It is very clear that applying GenFund, HA, and CA series is not just about the technologies, it's about the precise clinical strategies. In my opinion, I have a strong remember on you said that the hemoadsorption can reduce the dose of vasopressin dose that we in China we see that in the patients, many other patients like the cardiosurgery patients or the autoimmune disease patients, we also see that syndromes or the use for in hemoadsorption in these patients. So maybe I think it's the connection with the microcirculations or antiviral functions protections, some kind like that. So many thanks for your topic. And after that, it's my great honor to invite two other most influential figures in critical care to the stage. The first one, let's welcome Dr. Hakim Yusuf. He is the constant of the intensive care medical medicines, ECMO, and anesthesia University Hospital of the Leicester NHS Trust, the Leicester from United Kingdom, and he also is the honorary senior lecturer from University of Leicester, deputy head of the service anesthesia from Greenfield Hospital. Let's welcome Professor. If you have some, and for the audience, if you have some problem or want to ask some questions, you can type your question in the chat box. So please, Professor, if you have some suggestions or discussions with the first two speakers, you can have the discussion with them. Thank you.
Thank you very much. Thank you very much for the very, very interesting presentations. And I think the first thing to say is that the results of your studies are quite congruent with what we've seen worldwide with research involving hemoadsorption. And in my research group, we are actually I think when we're talking about going forwards with the utilization of a hemoadsorption in critically ill patients, I think two things come to mind. I think the second speaker spoke really well about dosing and dosing in terms of flow rates and the early use of hemoadsorption. But I also think there is some granular pathophysiology that we are still unable to characterize really well. And that has to do with the phenotyping. I think, broadly speaking, we talk of the hyper and the hypoinflammatory phenotypes, but I think they're not two distinct groups. I think they exist on a spectrum. And I think this is why we're actually really struggling to when you do big studies on hemoadsorption, you're struggling to find a good evidence. There actually, I think there's a sub story to the phenotypes that is beyond just the phenotypic presentation. I just presenting with high dose inotropes or vasopressors, because I don't think that tells the whole story. So, I mean, if you look at the literature, I mean, there's a very interesting paper from, to be honest, I would like to empathize because I agree with Dr. Rathina because I'm running a study myself on HA380 about the difficulty of running a study of this nature and being able to have a good recruitment rate. It's really difficult. If you want to be puritanical and select a specific patient phenotype, you will struggle. And it is not just, you're not the only one having this problem. We've seen it in everything. I mean, I do ECMO. Standard ECMO studies take 6 years to recruit 200 patients around the world. So this is a difficulty. And I have some suggestions, and I'll pose it to the two speakers at the end of what my suggestions are, which is something we are trying to do in ECMO, which I think would actually also work with this. But I want to discuss, I just want to discuss how you guys feel about the phenotypic characterization of patients who are inflamed. Now, as you mentioned, sepsis is a very good point to talk about this because actually, if you notice in the pathway of inflammation, several processes can come into it. You can have surgery, you can have trauma, you can have acute pancreatitis, a good case in point that produces fluid inflammation. And then you have sepsis, creates a septic shock. But actually, if you look at it from a phenotypic presentation point of view, they're very similar in terms of the processes that occur at tissue level and a macroscopic level. And the way the patients present are very similar, apart from treating the primary cause, the effect on organ dysfunction and organ outcomes, acute kidney injury, severe cardiogenic shock are similar. Now, but I think there is one factor that I think we probably need to actually study a bit more, which will actually kind of help us understand the right sort of patients who benefit from this. I think there's nothing we can do about the process. The insult is the insult, and the insult occurs early, and we know the insult occurs early. But I think the patients are at gene level very different. So we have very different patients. So there is a very, very interesting study that was published they're just looking at the time difference. It was published in the Blue Journal last year, March 2025. And basically, this was trying to look at basically, they looked at the MARS trial, the alveolar trial, and the CLOVER trial. These are trials that looked at ARDS and looked at hypo to hyperinflammatory phenotypes. And what they've done is taking certain immunomodulators, interleukin 6, interleukin 8, bilirubin, things that we know are quite associated with high inflammation, and did latent class analysis and divided the patients according to the transition from hypo to hyperinflammatory phenotype. And actually, they came across with 4 classifications, which is very interesting. So they came across with a hypo to hyperinflammatory phenotype. Now, that is easy. We don't need those patients. Those patients do well. And they wouldn't present with a lot of inflammation. But then there's a hyper to hypoinflammatory phenotype. Those are patients who go from hyper to hypoinflammatory phenotype between 24 to 72 hours. They have a those are the predicted patients. So if you're going to talk about the classic patients who have hyperinflammation, they are the classic patients. But then you have a variation. You have the hypo to hyperinflammatory phenotype. So they start off as hypo and then they become hyper. Their outcomes are worse. And then there's a hyper to hyper. So they are sustained hyperinflammatory phenotype and they have the worst outcomes. Now, if you put all these 4 patients, if you did a study, big randomized controls trial, and you put all these 4 patients, unfortunately, the phenotypic effect of the different characteristics of these 4 groups will dampen your effect. And this is the problem. So it's about identifying specifically those patients. I think the 2 groups we're actually really interested in are the hyperinflammatory phenotype and the hypoinflammatory phenotype. Because very interesting thing about hypoinflammatory phenotype is that it calls into question that mindset that you have to apply hemoadsorption or immunomodulatory therapies early. We know some patients will actually become hyperinflammatory later. For example, you've got a patient who's, low grade, develops a VAP or has a progression of disease. The typical ones are pancreatitis. They come in and they look really well, but their inflammatory course is progressive. And actually, it can even become much worse, beyond that 72-hour window. So that's something I don't know if you guys can ponder about. It's something that is very interesting. The other thing is about, I think we need to broaden our criteria for understanding patients who are hyperinflammatory. It's a very good paper published in the Lancet Respiratory in 2023 that actually looked at a whole raft of spectrum of identifiers of hyper and hyperinflammatory, and actually it's quite broad. There's a lot more we can include into this. And one thing that my group in Leicester we've looked at is age. So there is a concept of inflammaging. It is a low-grade, non-pathological inflammation that occurs in people as they grow older. And actually, we did a big analysis of, this is in response to cardiac surgery, of organ damage post-cardiac surgery in different age groups. And we found that actually as you grow older, the effect of inflammation on organ dysfunction is less defined. It's actually very heterogeneous. And actually in the study that I designed, what we've done is exclude the elderly because of that, because that's another thing that would skew your picture. So these are very interesting signals. And so my proposal and a question to both of you is this: are we better served, rather than doing big randomized controlled trials, are we better served by using a registry-based, which is what we want to do in ECMO now, registry-based prospective analysis of patients who are on hemoadsorption? And that allows you to collect a lot of data in serially, it's continuous. So you have a pre-specified registry, qualify the data entry. We broaden the definition, so the data identifiers of hyper and hyperinflammatory phenotype, and analyze that. And I think what that does over time is allow you to streamline a really precise group of patients who benefit from hemoadsorption better. I think traditional randomized controlled trials are difficult. Is my observation. Thank you very much.
Thank you very much. I agree with you. The real problem for our countries like Thailand is that we have some problem with the treatment which has like a guideline don't recommend. So how the payment of the government payment said no, if you need to do in large group, we have to look into specific kind of patient which we have gonna have like a beneficial effect. That's why I conduct this study. It's quite difficult for some kind like in Thailand or other Southeast Asian, except Singapore in our regions. It's difficult. But as I agree with you, I have opportunity to use the hemoadsorption by HA330s during the COVID-13 patient era. At that time in Thailand, we don't have interleukin-6 antagonists. So we in some case we use, in some case of ARDS on ventilator, we use this kind of treatment. and we published one papers compare between treat and not treat with CA35. Actually, not trend, is associated with taking off like a winning of ventilator, better winning of ventilator. And interestingly, I can do hemoperfusion in pregnant patients very safely with this kind of treatment. This may be because in COVID-19, the level of cytokine storm is not as high as in sepsis. It's like, in the middle ways. And at that time, we treat like your light register, as you mentioned, we treat in very large group. Our government said that, okay, at that time, anything you can do, you do it. But right now, we can do like that. We can use the cartridge freely in our country.
Or off license, yeah. And that's a disadvantage. I actually think that if we're going to do it, it has to be worldwide so as to get a plurality of experience. The other point that you raised, which is a very valid point, is a comparison with COVID-19. COVID-19 gave us an opportunity to cluster ARDS. So ARDS is rare, the incidence is falling, we all know that. But what COVID-19 gave us is a rapid increase in incidence in ARDS occurring in a short period of time. So we had the opportunity to study these patients really well. And it threw up a lot of insights into how to manage these patients. I manage patients on COVID-19. Unfortunately, we didn't use the cytokine absorbers. The worst we used was Oxiris because we had supply issues at that point. Now, there's one very, very interesting thing that you mentioned, which I think is a very, really good point, and I think I've discussed this with a lot of people, is that I think, personally, I think we're going to study cytokine absorption. The outcome you should look for is not mortality. I think we should look for a surrogate of mortality. I think looking at the pathophysiology of sepsis or acute inflammation causing organ dysfunction, when you have attenuated the hyperinflammation, there's so many things later on that can lead to death of that patient that actually it starts to confound your intervention. Intervention is occurring very early. Before that patient leaves hospital, 28 days time, a lot of things can lead to the death of that patient, and so I think it makes picking out a signal of benefit very difficult. So surrogates of outcomes, like you mentioned, ventilation time, length of time on ventilation, length of time on requiring extracorporeal support, length of time requiring vasopressors are really good insights. I don't know if you remember from the vitamin C trial that was done in Southeast Asia, and that's a very good trial, a very good case in point. The initial Marek, who did initial study in the States, used mortality and it had a big mortality difference. But actually, mechanistically, when we used a surrogate of outcome, there was no difference in outcome. Actually, if anything, there was a signal of harm. So, and I think for this, and I'm not preempting the results of my study, but what I am noticing in my practice is that it is those reductions in organ support, in requirement for vasopressors, that are the immediate mechanistic benefits that you can glean from. And I think we should use that to study rather than mortality. I think mortality is difficult, is what I'm going to say.
Yes, Professor, I'm strongly agree with you. It's very hard to have the difference in the mortality. So in China right now, we have some evidence research in the like VIP doses and endocellular functions and SOFA 2.0 and the new scoring for the organ protections. In this area, we have established some research. So I'm strongly agree with you. Thank you, Professor. Now that's
Thank you very
welcome.
much.
Now let's welcome the other professor from Philippines, Dr. Roland. He is the head of the hemodialysis unit and transmission nephrology clinic is Avenue Medical Centers, Quezon City, Philippines, and he is also the fellow of the Philippine Society of Nephrology, the fellow of the Philippine College of Physicians, and Dr. Roland is the actively engaged in the clinical practice and the medical training and research. Let's welcome.
Good afternoon. Good evening to everyone. Again, I'd like to thank Jafra. Am I clear?
Yeah, yes, sir.
Okay. So first off, I'd like to thank Jafron for this, for the invitation. Um, well, taking off from what you mentioned about mortality outcomes, and I was quite amazed at the fact that the what Dr. Fetty presented, his particular paper, quite mirrored what an unpublished paper that we have here at East Avenue Medical Center in the Philippines. So we actually did a similar study looking at clinical outcomes of patients who underwent hemoadsorption for sepsis. Now, the sample size was quite similar. We had like 80 patients, and 30 of them 30 patients had undergone hemoadsorption. However, our controls were quite different. We made use of historical controls because at that time, hemo Philippines in our institution. So we made use of the 2019 data. And these particular set of patients underwent were given the standard of care for sepsis. Now, the 2023 group underwent hemoadsorption. Now, the results were quite similar to what Dr. Fetty had, Dr. Professor Gol had. We actually had a significant reduction in 28-day mortality. The hemoadsorption group only had like 10% mortality, while the standard of care group had 40. Hold on. There. Let me see. The standard of care group had 38% mortality. So I was quite happy with the results that I saw from your particular study. Although our study did not delve into all the biomarkers, we did not look into the inotropic support or the time to withdrawal, because we had problems with data collection, especially with the historical controls that we made use. However, in terms of like hospitalization stay, the hemoadsorption group fared better. They had shorter hospitalization stay. But the ICU stay was shorter for the hemoadsorption group, but the total hospitalization stay was quite similar between the two groups. So essentially, a major critique of some of the infectious disease specialists in the Philippines, or even some of the other specialties of hemoadsorption, is the lack of clinical the lack of studies with showing clinical outcomes. Now, this particular study that the section of nephrology did, it clearly shows that there is survival benefit with hemoadsorption. Now, although some differences did occur, because at that time we were still trying to find the appropriate dose. So at that point, we had like 60% of the patients doing 3 hemoadsorption sessions, while 40% had 4 sessions. So we were still trying to find the adequate dose, or we were still trying to fix our protocols at the time. But on different sides of the world, we have more or less the same results, and I'm quite happy to share our data, and definitely I will be sharing your results to our local practitioners as well. And right now we're trying to expand further the use of HA330. As mentioned earlier, with regards to the timing of starting the hemoadsorption therapy, we're looking into burn patients. Since East Avenue Medical Center is the National Center for Burn Management, so we get to see a lot of burn patients. And the thing about burn patients is that we know the time of insult, we know the time of state of hyperinflammation, and as you can see, and that's the advantage of treating burn patients over those patients with sepsis alone. Burn patients, you have a definite time frame. You have that 12 to 48-hour window wherein you can actually address the hyperinflammatory state. And so far, we've been seeing promising results. We are hoping that we could gather more data and hopefully have the paper published soon. And yeah, okay, that's it. Thank you.
So thank you, Professor. So so we come to the next sessions. So in these sessions, everyone audience online can, if you have the questions, you can type in the chat box and discuss with the 4 experts online. So I see someone is asking, I want to ask to Dr. Ranista, is CA330 only for endotoxin or can do for the cytokine also?
Actually, for CAT30, I did not have used this before, but as I saw the paper from group of Professor Rongo in vitro, they show that CAT30 can absorb both endotoxins and cytokines. But it may be more expensive than HAT30s. So if I have opportunity for use this kind of absorbent, maybe I select these CAT30s only for the first day, for example, and rather than, and like as I show you, maybe 4 ounce or 6 ounce and use 2 cartridges if possible. If no financial constraint, we can use for the first day, and after that maybe we can change to HAT30s according to the pathophysiology basics if you need to use. If you don't have any problem regarding the sponsorship or money, you can use CAT30 maybe for 3 days, but I do not have experience for the new softband from Jaffron right now.
Thank you, professors. And the other question is, who is better, CA330 or HA330? I can answer this question. It's 2 kinds of cartridges for use in the critical care patients, but the CA330 has more ability to absorb the cytokines than HA330. And the third question is, so should HA330 not available, can we use the HA330 for liver failure since it will have the same mechanisms? So maybe Dr. Fatigue, could you answer these questions?
Still, we have just used HA303, but in some cases we use HA330 for liver failure. And so in our country, we have just HA330, not other type. And also we show some, in some cases, it was very effective. But we have just HA330.
Okay, thank you, professors. I have a questions for you. Uh,
I'm sorry,
sorry.
if I may answer to that question, sir.
Of course.
Okay. Okay. Well, in our setting, we have both HA330-2 and HA330. In terms of I believe in terms of porosity, there are subtle differences between the two, and you expect better bilirubin clearance in patients with HA330-2. We've seen better improvement in terms of hepatic encephalopathy in patients who make use of the 330-2 cartridge. You see immediate improvement in their mental status after the first 2 sessions. So, yeah, there are although there were instances wherein we had to resort to making use of 330 since the -2 was not available, but there's a clear difference in terms of clinical outcomes, especially in addressing hepatic encephalopathy. Thank you.
Okay, thank you, sir. Thank you, Professor. I have a question for Dr. Fatih. It's from the medical team. So right now we have focused much more attentions on the modalities and the cytokine storm and the hemoadsorptions. But for the future, we want to establish more research on the microcirculation functions and the situation of tissues, hypoxia, and the protection of organ functions. Should we conduct research on the pathophysiology mechanisms in this field? So I have these questions for experts, please.
First of all, may I say something at this point? I think the immunology part of this sepsis is very important. It is very difficult to select the real patient. And we have some biomarkers also now in usage. We cannot differentiate hyperinflammatory and hypoinflammatory patient. Sometimes it is very difficult, really very difficult. So we have to look to patients if there is an immune paralysis occur or not. And we have some biomarkers, for instance, HLN may be one option because the level of HLA, if there is a decreased level of the HLA, so it means an immune paralysis condition. And so in presentation of Ranita, she said it is useless if there is a immune suppression. And this is the gold marker for us, because during the hyperinflammation phase, and I show in my slide, I show 3 types of the patients, 3 types of the profile for the patients. For instance, a younger patient, please think a younger patient with meningococcemia, you can see a fever response because of sepsis, but it is not true for a old patient who has some comorbidities such as renal failure or heart failure. And this patient fever response is very low. So biomarkers are important, but I think it is not 100% true. Also for interleukin-6, we have not only interleukin-6 levels, but also we have interleukin-6 receptors. And we know interleukin-6 receptors behavior look like an anti-inflammatory. So not just the interleukin-6 levels, but also receptor levels are very important. At the level of clinical usage, I think it is not so easy to differentiate this type of the patients, but major treatments usage at the level of, according to Surviving Sepsis campaign, the not too late phases, but maybe it can be an intermediate phases for septic shock. And according to clinical response, we can differentiate, because not just a interleukin 6 or 1 level is a descriptive mention for this type of the treatments.
Can I add to that comment? So I think we have to move into sort of using omics and proteomics to identify tissue level markers of inflammation. And as Dr. Fetty really said quite clearly there are certain receptor markers and some genetic markers that actually identify patients who are hyperinflamed. And I think actually they have the potential to be more precise. Good thing, I don't know about the rest of the world, but in the UK, doing omics research is getting cheaper. We have more people are doing it. Genomics is the future, I think. And so sort of research to kind of identify cell level, mitochondrial level biomarkers of inflammation. There is a study we are doing in the UK at the moment. I know you're all probably aware of long time ago we studied using simvastatin to see if it improves ARDS, and there's no outcomes. And it has been looked at again because actually we now have a near bedside test that can identify sort of raised interleukin 6 levels to prognostically enrich a group that are hyperinflamed and see if there's benefit there. I think prognostic enrichment is going to be the future. So you identify the group, prognostically enrich the at-risk group, and then apply the intervention. Some biomarkers that have been identified are things like tissue necrosis factor receptor in tissue level. We also have intercellular adhesion molecules that have been identified at tissue level that can be used. And actually, there are quite a lot of publications that have identified this platelet adhesion inhibitor factor 1, and these have been quite well characterized to be associated with high inflammation. So it would be to look at it in a population group. What has limited this over time, like I said, has been the cost. But the cost is coming down. I'm talking about Europe. I'm not talking about the rest of the world. But I think that's sort of the direction, actually, in terms of identifying prognostically enriching a group of patients who will benefit the most from this. Last thing I want to say is that I think one very simple group, which Dr. De La Cruz identified as burns, I 100% agree. They are a very simple group. The pathophysiology and the phenotype is very clear. There are very few conditions that cause hyperinflammation like burns, and you can easily track them. So that's an interesting group. Unfortunately, they're not a big number. If they were a big number that you can study as a surrogate, then we can use that. But unfortunately, that's probably not a big number. But I think that's a really interesting group.
So can you share your opinion, Dr. Ronan?
So again, with regards to like looking at burn patients, it's quite fortunate that the hospital is the National Center for Burn Care in the Philippines. So we tend to receive patients in their hyperinflamed state. So and fortunately, we're trying to do a study. We're trying to look at patients who essentially have more than or about 20% total body surface area affected by the burn injury. And of late, we've been getting very good results, very promising. Although again, the results tend to vary in certain situations, especially if we get them late. If the patient had to come from a different province, and more often than not, we receive them beyond the 48 hours. However, we still continue to do the hemoadsorption for this subset of patients. We will try our best to try to look into the interleukin levels if we can ask funding from the hospital, from the Department of Health. Hopefully we could get that and add to whatever information that we have on biomarkers.
Oh, thank you, sir. Thank you, sir. So what's your opinion, Dr. Ronita?
For my opinion, for the biomarkers like interleukin 6, for example, in our hospital and our country, we have that one. In the literature, there is association between CRP and interleukin 6. So I would recommend the use of CRP because for interleukin 6, as I show in some slide, the level of interleukin 6 is quite different from, for example, from 100 to 1 million, for example. So how can you see before and after treatment for the decrease from 1 million or decrease from 100? So it's difficult to see, especially when you compare with standard treatment. If you compare just before and after treatment for observational study, you can see, okay, after treatment, the decrease of the level. But if you see comparing between equality, like in this group of patient and another group of patient with similarly in terms of severity, but the level of interleukin 6 is quite different. I can see in the intra-abdominal injury and intra-abdominal abscess or bowel perforate, the level is achieved like 1,100. Whereas in pneumonia, elderly pneumonia in elderly, the level is going to be only 100. Both of them has higher level of CRP. The blood pressure show very low, while pulse pressure like pro-inflammations, hyperdynamic shocks, similarly, but different so I in my view, the biochemical something is something that we should not use this time, especially like for endotoxin level EAA assays. You can see for polymyxin treatment, when they use the higher level of EAA higher than 0.6, the trial gonna be similar. 0.6 to 0.8, similar again. So I think hard evidence may be surrogate like if clinical like shock reversals, but for biochemical or biomarkers, maybe we need to seek something like proteomic or others, not cytokine level or endotoxin level, in my view.
Thank you, Professor. This situation is totally same in China right now. Many China experts says that if we will only focus on the cytokines, we will not have the better outcomes. So we will need to focus on the other, like the organ protections and the other ways. So many thanks, every expert and professors. We have come to the end of the very protective symposium today. We have heard the latest research from the global professors and had experience discussions with everyone. So I hope you found today's sessions is available and that you can take some of these state-of-art strategies back to your hospital for all the audience online. As we conclude, I wish you all great success in your professional work and more importantly, health and happiness in your personal lives. May your journey ahead be as rewarding as the work you do every day in the hospitals. Thank you for joining us today. I'm looking forward to seeing you again. Thank you, every professor and the audience online. Thank you, everyone.
Thank you. Bye.
Thank you very much. Thanks for having me.
Thank you. Thank
Thank
you.
you.
Thank you very much. Thank you.